Welcome everyone to session 6 of our building pathways to fertility preservation and cancer echo. The question that you've been asking for so long, we're finally addressing how to pay for fertility preservation. So as always, we have some quick housekeeping and disclosures. Each echo session will be recorded and will be posted to our publicly facing ACS Echo website. You can find this session as well as previous session and all the resources that we've mentioned in all the sessions on our website. Please use the buttons in the black menu bar to unmute your line and turn on your video, especially during the discussion. We would love to see everyone's faces. Please remember to not share any personal health information about any patient as we're having discussions today. And questions about Zoom, please type them in the chat to me directly. Here is today's agenda. We're finishing up our welcome and announcements. We will go through our featured resource. Then we'll have our clinical presentation, lived experience expert presentation. Then we'll have a robust discussion again, because I know you guys are going to have questions. Then we'll end with our feedback survey and wrap up. And we will have our didactic and our lived experience expert back to back. So if you have a question while either Joyce Renke is talking or Katie McKnight is talking, please don't wait to ask. Put it in the chat. We'll make sure to address it. So here is our featured resource for today. This is a set of insurance-related toolkits that were developed by a team of researchers at UCSD Moores Cancer Center and the Alliance for Fertility Preservation. It contains this specific one that's on the screen, but there's multiple toolkits, and I'll let Joyce talk about that in a second. But it's their toolkits for stakeholder groups related to phone scripts, template appeal letters, and help to navigate fertility preservation coverage. There's a QR code on the screen to scan, but also there's a link in the chat to have access to these toolkits. And I'll let Joyce chime in on anything else she wants to add besides the summary that I just mentioned.
Thanks, Allison. Yeah, I'll just say the original toolkit was developed as a patient toolkit to help patients understand insurance better. There's a glossary, things like that. There are videos that patients can watch that, talk to them directly about parts of this process through, the complexity that is our health insurance system. And out of a grant and a subsequent symposium that we held, we got a lot of feedback on recommendations for other stakeholder groups, like regulators and clinicians and all of that. So additional versions of the toolkit are there. So some of the pieces of the toolkits are redundant, and probably what would be most relevant for all of you guys would be the one for clinics and the one for patients. And I'll just say, don't be daunted. There's a lot in there, and there are going to be some pieces, that you'll find, useful yourself or useful to share with your patients. So, and please reach out if you have any questions about the toolkit. Thanks.
Awesome. Thank you so much, Joyce. And I looked through some of these toolkits, and there's so much amazing information in them. So please take advantage. Again, link in the chat, QR code on the screen. A link for this is going to be on our resource list that we've been created each session. So it will live on our website as well if you ever want to, look at it again and you can't find the resource. So thank you so much, Joyce, for providing that. If you have a resource, we have one more session. We need one more resource that you want to share with the group. Again, QR code is on the screen. There's a link in the chat. But if you found something really helpful that you've used that you want to share with the group, please let us know, and we will share it on our last session. So with that, I want to introduce Joyce Renke. She is the Executive Director of the Alliance for Fertility Preservation, a national nonprofit organization that's focused on all aspects of fertility preservation for cancer patients. She is a recognized leader in the field of fertility preservation, who has been a featured speaker at numerous professional conferences, including ASCO, ASRM, ONS, the Onco Fertility Consortium Conference, as well as serving as a guest faculty for health policy graduate courses at UC San Diego and Northwestern. She's a co-author of the 2018 update of ASCO's fertility guidelines and several other publications. She's a long-term survivor of, oh my gosh, I'm totally gonna screw up the leiomyosarcoma. I probably mess it up and I apologize. But she opted for embryo freezing and surrogacy to create her family. Her personal oncofertility journey informs her professional focus and her commitment as a patient advocate. We are so happy to have Joyce here today, and I will turn it over to you.
Thanks so much, Allison. Yeah, hi everyone. I'm Joyce Reinecke, and thanks for your interest in this session. My background, as Allison said, is as a cancer survivor, and I've been increasingly focused over the years lately on legal and policy advocacy around fertility preservation, primarily to try to get coverage and get people better access to reduce the financial burden that they're facing. And as Allison said, this is deeply personal work for me and grew from my own experience. So thanks for being here. Next slide. I have no conflicts of interest to disclose. And I guess we'll dive right into what the learning objectives for this session are. So first, we're going to look at financial challenges that are facing newly diagnosed cancer patients in general and how those intersect really with fertility preservation and why this intersection, is uniquely burdensome, frankly, to younger adults. We're also going to get an overview of the U.S. health insurance system, just to, I guess, kind of help equip you all and have you feel more confident about navigating that with your patients, and just talk about how important that is in getting access for patients to fertility preservation. And lastly, we'll talk about some strategies for navigating patients through financial obstacles for fertility preservation. And then I know our lived experience expert has a lot of specifics on that, especially with regard to insurance appeals. Next slide. Okay, so just to kind of get us, level set here, I am going to touch upon financial toxicity, which I know there are already some great resources within ECHO that focus exclusively on this concept. What we have here is to look at the National Cancer Institute. This is how they define financial toxicity. There's not like one, definitive definition of this, but they define this as the problems a patient has that is related to the cost of medical care. And it's not just about, big numbers, hospital bills, things like that. It's also the detrimental effect that costs have on many aspects of a patient's life. So the material burden really is about those hard costs, right? Uncovered medical costs, out-of-pocket costs, lost income. And all of that gets coupled with then the psychological distress of having to worry about that financial burden. And that's how the NCI defines that combination of factors can lead to financial toxicity. And that toxicity can lead to long-term financial instability, but also to negative clinical outcomes when people skip certain treatments or certain, oftentimes essential, other expenses in their life. So we know this is a serious issue, and we're going to move on and talk about how fertility preservation adds to that burden. So it really adds an entire level to the financial burden that young adult cancer patients and survivors face. Studies have really shown that of course, it's the same group of patients, right, who need fertility preservation, those who are younger, who are at the highest risk of financial toxicity. And those factors that drive that combination of risk and amplified risk are some of the things I mentioned, like being at an earlier stage in your career, having fewer, less robust savings to begin with and having to disrupt your work or your educational path. So, on top of that, fertility preservation itself, as you all probably are aware, can add really significant upfront out of pocket costs that increase that material burden on patients. And a lot of that burden really arises, which we're going to talk about, out of the fact that insurance coverage for these services is usually non existent. And even when it exists, it's often limited, and patients will still incur additional costs, even if they have coverage. So the way that this adds to the burden has been quantified a little bit in some studies. There isn't a lot of data, but one study found that women who had undergone fertility preservation actually had 1.5 times the rate of financial hardship. And the researchers there defined that financial hardship as going into debt or borrowing money to get through your medical treatment. And so that was 1.5 times the rate for patients who opted for fertility preservation versus the patients who did not. In addition, the extent of the debt that they had incurred was also higher than their peers who did not undergo fertility preservation. So, in the fertility preservation group, for instance, about 12% reported that they had taken on more than $25,000 worth of debt, where only 5% in the non fertility preservation group had that scale of debt. And I guess lastly, I just want to also mention that these costs are not confined or ending with active treatment, right? So it's not just the cost of fertility preservation itself, it's that post-treatment family building can also be really expensive. And having coming out of treatment with financial toxicity already is going to make it even more difficult to access those family building services like going through IVF, to use, whatever material you may have preserved, to opt into surrogacy, which is extremely expensive, or to go through a process to adopt. So it's a continuing burden for young adult patients. Next slide. This is just an overview of the typical costs of fertility preservation. This is something that we just updated recently on our website. Again, it's kind of hard to get this data, which sounds kind of silly, but there are really broad ranges of costs depending on where you are geographically. And there's not really like a national average, if you will, that is published out that's definitive. But we know for women, the standard options, really the most relied upon options are egg and embryo freezing, and those cycles cost several $1,000s. And then in addition, you have the costs of medications, which also can run from hundreds to thousands of dollars. So for men, we see that sperm banking is, of course, much less expensive, but we still hear about it as a barrier. It's just an additional cost on top of what young male patients are facing. And of course, storage adds to this. So depending on how long you need to hold on to those materials and get through treatment and then get to the place where you're building your family, those costs add up as well. Next slide. So the way that I've been thinking about this and I wanted to share with you all is to think about those NCI identified categories that create financial toxicity, which are the hard medical costs and the burden of that, and then the emotional distress that causes. And with fertility preservation, we then add another layer of challenge on top of all of that. Arising from logistical challenges that fertility preservation presents in addition to the financial burdens, right? And that, as you know, arises primarily because of the tight timeline that patients are facing, and having to make these decisions in a really quick way, but also having to undergo the treatments, the services. So for women, that's going to be a minimum of 10 to 14 days before they can do an egg harvest and freeze eggs or embryos, and they have to get that done before they start cancer treatment. And so, of course, as we know, schedules may not align very well, and it's especially a challenge if there are geographical barriers, right? So not all patients are going to live close to or have easy access to sperm banks or to reproductive clinics. So once again, we see fertility preservation right there at the center, touching upon all of these components of financial toxicity and adding to them. Next slide. Sorry, this was just my reference slide. I couldn't fit everything on there, but if you are really interested in the intersection of the financial toxicity of fertility preservation with kind of broader concepts of financial toxicity for patients, these are really good resources, and they will be listed in the resources. Yes, Allison? Okay. Thanks. So I want to just move forward a little bit into understanding health insurance. And I know this sounds really basic, but I think it's worth taking a step back and thinking about how health insurance is supposed to work. And it's supposed to really be covering, you know, any and protecting patients from catastrophic medical costs and getting you those services that you need for a medical issue. That's kind of the basic definitions that you see here. And we know from studies, there's a Kaiser Family Foundation quote that health insurance is really the means, the mechanism that people rely on. Most people are not paying for their medical services out of pocket. So it's an integral part of this. Next slide. So, one of the biggest challenges that we have in the US healthcare system is that we really don't have a system. We have multiple systems of insurance that coexist. There are there are employer sponsored plans, which is where most people get coverage for benefits. But there are also individual and small group plans that are sold usually on the state exchanges. There are public programs like Medicaid and Medicare, and there are some other coverages like at the federal level, military coverages and federal employee benefit plans. So it's important to understand that all of these types of insurance have different rules, have different mechanisms for payment, for reimbursement, for appeals. And so that's what really complicates a lot of this process of navigating a patient through this. You have to be really clear and understand that coverage is going to depend really heavily on where someone lives and what type of plan they have. Okay, next slide. So this is I find this slide a little bit overwhelming, but I just want to give you a sense of the regulatory aspects of this. There's really plans that are regulated at the federal level and the state level. And so, as I said, on the federal side, there are military coverages, there are employee plans for those who work for the federal government, but there are also what we call self-funded plans. And that bucket of plans is really where more than 50% of people in the United States who are insured get their insurance through large employers who basically step into the shoes of becoming the insurer and absorbing and taking on the financial burden of that and creating what we call self-funded plans, where the insurance company that you might see on your insurance card is actually just administering that plan. And they're really not the one who has the liability that's tied to any benefits that have to be paid out. So that's kind of complicated. On the state side, Medicaid is a state and federal partnership, of course, but most of the rules for what's covered there, other than the absolute essentials, are done at the state level. So we can legislate to add Medicaid coverage through state legislation and bills. There are state employee plans there. And there are what we call fully insured plans that are regulated by the state that an insurance company actually just sells to businesses. And there are the state exchanges where we see individuals able to purchase plans or small group plans that are purchased. So this distinction, oh, sorry, just one second. The distinction about a plan and understanding if it's a self-funded plan, usually, which is where we have the problems, versus a large group plan is really, really critical. And sometimes it's actually hard to get to and hard to understand. And we always recommend that if you have a patient in front of you, that you look to their benefits plan. And if you look at the appeals process, you'll see the regulator name there. And that can give you your first kind of step in understanding whether this is a state plan or a federally regulated insurance plan that probably doesn't have coverage and is regulated by something called ERISA at the federal level. So that's what we see as usually the biggest source of confusion with regard to plans. Next slide. So the good news is that there are studies that show strong evidence that insurance coverage, when it's in place, does really work to the end that it's purported to be about, which is increasing utilization of needed healthcare services, also of reducing financial hardship. That means lowering out-of-pocket costs for patients and creating less medical debt for them. And some studies show improved clinical outcomes, especially in certain types of services like mental health and chronic disease care. So I know that sounds really basic too, but it's really, I think, fascinating that these hypotheses have been really checked, and they hold steady across, the really rigorous, comprehensive studies that look at whether insurance really does have this beneficial impact. Okay, next slide. So what we're trying to do on a more kind of micro level, if you will, is look at whether those suppositions hold true when we move into the specific realm of fertility preservation coverage, right? That's the goal that we have. So what early studies now are showing is some positive trends. Now, of course, coverage has only started to take effect since 2017, so there isn't a lot of data on and the overall N, the absolute numbers of patients are small, so it's a little bit hard to measure this. But what we do know from these studies is that baseline utilization of fertility preservation is extremely low. And of course, we know that cost is often cited as the main barrier. So studies have shown only, less than 10% of men opt into these services. And one study actually showed that over one state's population, that there were only 1.2% of young adult women who opted into fertility preservation. But the trend is to move those numbers up over time. So we are hopeful that we will see increased utilization in places that have mandates for coverage. And there are some early studies that show that. So there was one study that showed an increase of over 100% and of 86% utilization in Connecticut and in Rhode Island versus only 64% growth in states that did not have any mandated coverage. I think one of the really positive things we've seen from some of this research also is that studies do show that there is a significant increase in consultations and in documented discussions of the risk and of the options of fertility preservation in states and in locations where insurance coverage has been put in place. So that is helpful in increasing communication. The next thing we do want to start to really measure with implementation as mandates take hold across the country is whether we're seeing real reductions, significant reductions in cost for patients, and whether we are seeing improved clinical outcomes. Next slide, please. So this is just a snapshot that we put together. This has to do with where there have been coverage mandates across the country. So we have this map that we've had for a long time that just shows states that have, the states in green have actually pass some coverage. Now, this coverage isn't comprehensive. It doesn't cover every type of insurance group, or so every person is not covered necessarily, but they've actually done something legislatively and taken action to expand coverage. So up to date so far, we've seen 21 states and the District of Columbia do this in this way. The blue states are states that have tried and have introduced legislation for coverage, but have not yet passed it into law. The yellow states have also tried, and those have failed. The blue states are active this year. So as of last week, when we were updating the map, we update it every week. So you can see if there's anything pending in your state and get involved. At the federal level, the Federal Employee Health Benefits Program has implemented coverage, and the Veterans Health Administration also has longstanding coverage. So that didn't come through, those benefits at the federal level didn't come through legislation, but they came through administratively, and those coverages do exist if you have patients who have those kinds of insurance. Medicaid has only been introduced and put into effect in 6 states, and there's some issues with those coverages and many barriers that are specific to Medicaid that we can discuss. But we are seeing a trend where states that had early adoption of coverage are going back and trying to add Medicaid, although it's very difficult, at this political moment. The other thing to know about these coverages is that they are extremely heterogeneous. So they are different in every state, and those compromises as to what's included. So for example, is a patient entitled to 1 cycle or 2 cycles? Are they entitled to, do they include storage costs, things like that? Those really vary, and so you would have to dig into the specifics of each of those. And the only other thing I want to jump in with here is this is what we look at as our legislative coverage map, but we have just as of today added a new map, which is an interactive coverage map. So if you're curious, like where is their Medicaid coverage, or where have states limited coverage and don't allow, coverage for embryo creation, things like that. Some of the permutations of coverage are accessible there, and that will be put in the chat or into your resources for you if you're interested in looking at that. Okay, next slide. So I know this is a big summary, and you've heard some of this, but I do want to say it's really interesting to dig into the literature and look at what is recommended. So consistently across nursing literature or research from cancer centers, these strategies are the ones that have really emerged for ways that you can help to reduce the financial burden on patients. So the first kind of tactic is to really be sure that you're initiating timely fertility preservation conversations. So by having this conversation as early as possible with newly diagnosed patients, you can maximize, especially for women, what their options may be. So obviously some options like embryo freezing, egg freezing take longer than something like ovarian tissue freezing, but you want to have a time frame to give patients the maximum number of options that they can, and then they can start really looking at costs. So of course, one of the ways to do this is to standardize these conversations using an EMR or some other system and documenting those discussions rather. The discussions should, as early as possible, really address costs so patients understand what they're facing. The next tactic that we've seen emerge consistently throughout the literature is to implement a really clear navigation workflow on fertility preservation. And usually that means assigning a point person, a navigator who's responsible for the process, and embedding throughout that process some kind of financial navigation step by step. Part of the navigation process, obviously, that's critical is to have a referral process to get patients to the services that they need as quickly as possible. Um, I would say then the third tactic is to strengthen your insurance authorization and appeals process. And so I think, I hope that some of what we just talked about would be helpful. I think the first thing is really understanding insurance, which is difficult, even for people who are in the healthcare field. And it's just an amazingly complex, you know, product to understand. So some studies have emerged that say when you're sitting with a patient and going through this process, what's most helpful, especially like if you are a clinician on the reproductive side, is to verify those services in real time before sending a patient into, accessing those services. They really need to know up front what is covered and what is not covered. Part of that process is working with maybe your billing department and understanding the codes for these services. Often we'll see claims that get kicked back because they're coded incorrectly and they're just managed incorrectly. And there's just a lot of administrative burden to that. I know in the toolkits there are lists of specific codes that you can be looking for, but that is an art unto itself as well. The other bit of advice that I think is important in this context is using templates to the extent that you can. So, as I said, like phone scripts or particularly appeals letters. If you're getting to the process where claims are denied, there are templates available for you so that you can get those out quickly and just adapt them for the particular patient and type of insurance. And then I'll say, I think, of course, it's important that where there is no insurance coverage or where there are gaps in coverage, that you can quickly connect patients to, those external resources. So there are a lot of grant programs, there are drug discount programs, clinics have discount programs, and really knowing that and having that list at your fingertips, I think is absolutely critical. So you don't have to keep reinventing the wheel and digging for these programs. I would also say if there are particular clinics or sperm banks that you work with all the time, it's worth maybe setting up or arguing for some kind of discounted programs. So those are kind of your tactics on approaching this. And I'm so sorry that I know that we wish that it were easy, and I wish I was coming to you with a silver bullet on how to make this all affordable. It is really a multifaceted, difficult, expensive process. So thank you for listening and being here to try to tackle that. And I will turn it over to Katie, who has lived through this.
Thank you, Joyce. That was very, very, very informative. And it's complicated, and I know we're gonna have a great discussion about it. So I'm gonna turn it over. I'm gonna introduce Katie before I turn it over to her, so she can give you a little glimpse into a lived experience expert who has dealt with things like this. So. With that, Katie was 29 when she received her first abnormal breast MRI and was later diagnosed at age 30 with an aggressive form of breast cancer. She serves on the executive board of Bay Area Young Survivors, an all-volunteer survivor-led nonprofit supporting breast cancer patients diagnosed under the age of 45 in the San Francisco Bay Area, and volunteers with the Alliance for Fertility Preservation to advocate for young cancer patients' access to fertility preservation and family building options. She works as a senior design manager and environmental scientist at the San Francisco Estuary Institute and lives in Richmond, California, with her partner, Nate. I'm going to turn it over to her and let her share a little bit about her journey now.
Thanks, Allison. Hi, everyone. I'm Katie McKnight. So nice to be here. Thanks for having me. So I'm just going to jump right into my story, and I hope it's helpful to think about, how other ways to get coverage for fertility preservation. So next slide. In 2020, I quickly went from being a very happy newlywed to my husband, Nate, and an environmental scientist, living my best life, to being a breast cancer patient. And yeah, thanks. And I was diagnosed with stage 2B triple negative breast cancer at age 30, as Allison mentioned. And little did I know at the time I would become one of the first patients to be in a first cohort entitled to fertility preservation under California state legislation that had passed the year before in 2019, called Senate Bill 600. Next slide. So just in case you haven't experienced cancer, hopefully most of you have not firsthand on this call, it's a really stressful time. There are a million questions coming at you at 100 miles an hour, things from, what type of chemotherapy and kind of treatment options are the best fit to, who should be your care team, to how you want to navigate additional tests and so forth. So it's just a really incredibly whirlwind of an experience. Next slide. So my diagnosis, hands down, was one of the most stressful times of my life, and it became even more stressful when I was really interested in fertility preservation after getting the diagnosis, but my health insurer very quickly started to delay that possibility. They basically told me I needed to do surgery first, then they would schedule me with an oncologist to discuss whether or not I needed chemo. But at the time, I got several second opinions, and all my other opinions said, no, actually, you need to do chemo first before you do surgery. You'll have more options. So I felt I really needed to get started on fertility preservation. Next slide. However, my insurer kept insisting that this was the right way to do it. And the fertility preservation office that was available to me was actually not that far in terms of distance, but with traffic in the Bay Area, it was a very long schlep to get there. So it would take around 2 hours to get there and 2 hours to get home. And as I was kind of in this initial stall period of not being able to get coverage under the law because of this weird thing where they wanted me to get surgery first and I disagreed, they wouldn't schedule me to get started. So I drove down to the clinic and begged the front desk folks to let me see the doctor, and much to my surprise, that tactic worked. And they let me see him and move forward with fertility preservation immediately. And they just said, we'll figure out the insurance side as we go. Next slide. So I started to do my research, and I determined that the best option for myself was to freeze embryos. I had my, husband and also partner of over 8 years at that point. We knew we wanted to have kids together. I also have a BRCA1 mutation, and I decided it was really important to me to screen my embryos. And in order to do that, you have to have an embryo. You can't screen eggs. And I wanted to know, how many I had to work with in the future, so I could adequately kind of preserve my fertility, more or less. But my insurer basically told me under the law that I was only entitled to freezing eggs. I couldn't freeze embryos, and that additional process I'd have to pay out of pocket, which would be upwards of over $10,000. So very quickly, it was clear to me that they were, trying to deny some of this. Next slide. And then I happened to cross paths with Joyce from the Alliance for Fertility Preservation through a friend. And I'm so glad I did, because she basically told me, I've heard of other people getting embryos covered. It's really standard of care under the SB 600 law, and you should be entitled to this. So, you can push back, you could file a grievance with your insurance, and because it's time sensitive, you can simultaneously file an appeal even before the denial comes in. And so I was like, great, I'm going to do that. What do I have to lose? And it was a lot of work. So you can see here all the steps that I took to move this forward. There was a lot of back and forth, a lot of letter writing on my behalf to advocate for myself and basically put my case forward of why I felt like I needed embryos, and looking into the literature to say, hey, this is standard coverage. And eventually, the Department of Managed Healthcare, who the appeal goes to, they're the regulatory body that in California that oversees insurance companies. They actually allowed my case to go to independent medical review. So tapping an independent, unbiased doctor who, is really steeped in fertility preservation and REI, reproductive endocrinology, to review the facts of my case, review my diagnosis, see if it's medically necessary, and make a ruling. But the one really stressful thing, I mean, two things really. I was already undergoing fertility preservation because it was so time sensitive. So during all of this back and forth, I was driving, 3 to 4 hours a day, doing daily injections, having transvaginal ultrasounds, medications, and so forth. All the while, on the phone on and off with different lawyers from DMHC. And they basically told me, there's no way we can guarantee that the IMR process will rule in your favor. And at the end of this, you could be liable for, $10,000 to $15,000 worth of medical expenses. Money I didn't have. My husband was a PhD student and I had to stop working. So it was a very stressful time, but I decided it was worth it to take the risk. Next slide. So it resulted in complete exhaustion, but I was very lucky to have 27 eggs, 8 embryos, and then of those 8 embryos, unfortunately, only one was BRCA-free and euploid. And so I still had 1 embryo though, so it was a success, but uh, less embryos than I was hoping for in the end that were BRCA-free. But the good news, next slide, is that in the end, a few days after my egg retrieval, I got a letter in the mail and a phone call saying that the independent medical reviewer sided with me. They overturned the decision of my health plan, and I didn't have to pay anything additional. So it was a huge relief. And the other benefit is that the ruling in my case became public record. And so anyone can look up in California the decisions of IMR reviews and get kind of a summary, if you will, of the findings. And the great thing about that is my case can hopefully help other patients in a similar situation use this ruling and say, hey, I'm entitled to this. Look at how they've ruled in the past. Next slide. But about a year after I finished chemotherapy, a thought kept creeping into my head about, if I was lucky enough to have my period return, I really wanted to do another round of fertility preservation. I just felt like one BRCA-free embryo just wasn't high enough odds for me to have a live birth. And so that's where I kind of went to next. Next slide. So I called up Joyce, of course. Now we've become friends at this point. And I asked her if under the SB 600 law, I could do and advocate for another round of fertility preservation after I finished chemo. And she explained to me that unfortunately the regulations of the law hadn't been finalized yet. So I fell into this gray area. And it meant that it might be possible to get it covered, but it'd probably be a lot of back and forth and there's no guarantee. And it's also very possible that it wouldn't be covered. So I figured, similar to last time, what do I have to lose? I had more time, at least this time around. I wasn't in treatment, so that felt nice. I could slow down a little bit. And I started to kind of go about the process in a similar way as before. Next slide. So this time ended up being pretty different. It didn't go to IMR because I didn't have a clear-cut case. Instead, much to my surprise, the California Attorney General's office got involved on my behalf, and they went up against my insurance in a mediation. And the irony to me was how many resources my insurer threw at this to fight me rather than just to let me do another round of fertility preservation. But that wasn't that big of a surprise because I think it's part of their business model, unfortunately. Next slide. And so, I found myself in this gray area, and the second time around, there were some really big key differences to the process. It took a lot longer because I wasn't in this kind of urgent medically necessary situation of having chemo right ahead. So it took over 6 months to do all this back and forth. And then, as I mentioned, it didn't go to IMR, it went to mediation. But in the end, I was very glad that my insurance company ended up having to cover another round of fertility preservation as a result of the mediation effort. So in August 2022, I made the drive back down to Fremont over a period of 10 days and had a second round of fertility preservation that resulted in another BRCA-free embryo. In 2025, I did my first embryo transfer, which unfortunately failed. And a few months later, I did a second one with that embryo from the second round of fertility preservation, and it took, which I was so excited about. Next slide. So now I'm 33 weeks along with a BRCA-free baby boy. We are super, super excited and cannot wait. My due date's April 12th. Next slide. So I'll end by just going over a couple key takeaways of what I learned in the process. So I feel like through my experience, insurance denials and delays are a calculated strategy, But persistence really does pay. I probably saved between $30,000 and $50,000 in advocating for myself. Um, I also think nowadays you can leverage AI to help you write your appeals letters. I wish I had that at my disposal back then. I encourage other patients to reach out to nonprofits and survivors and social workers and doctors because you never know who might be able to help you. And also ask about ways to protect your ovaries while on chemotherapy because I feel strongly that that's how I was able to do another round after chemo a year later. And then if you're a medical professional, I really encourage you to help your patients with the appeals process because even just a little bit of support goes a really long way. Next slide. So thank you so much for listening, and I'm very happy to take questions.
So we are going to stop sharing the screen and allow you guys to all ask questions of Joyce or Katie or anybody else. But first off, thank you both. Thank you, Katie, for sharing. I was seeing all the hearts go everywhere. So I think hearing from a lived experience expert, someone that's gone through it, really shows the impact. So thank you so much for sharing your personal journey, and we're excited to see a baby picture. But so let's get into it and see if there are any questions. Pull up the chat. Let's see if we have anything in there. Let's see. Just a lot of. Okay, so we have the first question. How did you protect your ovaries during treatment?
Yeah, great question. So there is, I know at least one medication, the one I was on, but I don't know if there are others that you can do as an injection that really shuts down your ovaries during chemotherapy. And by essentially shutting them down, the chemo doesn't target your ovaries because the cells are, I mean, I'm not a doctor, so I'm sure I'm like giving a very lay understanding of this process, but that's how it was explained to me that if you can basically induce chemical menopause temporarily, shut down your ovaries, that it's a bit protective. So the chemotherapy doesn't target your ovaries. And then for me, and I think it also depends on the age of diagnosis. So when you're younger, at age 30, and maybe like with my mom, she didn't go into menopause until 50, there was a really high likelihood that my period would return. I think it just depends on age and family history. But I know a lot of friends who have had similar experiences where they were able to get on medication to basically induce menopause during chemotherapy, and then they had good outcomes afterwards. I'm not sure, maybe others who are doctors can speak to whether or not that's like standard of care. I think it was a little bit experimental when I had it, but I felt like it helped me.
Yeah. Hi. Can you guys hear me? Yeah. Hi, everyone. Doug Fair. And I'm an oncologist. And Joyce, incredible talk. And Katie, what a story. Thank you so much for sharing it. Incredible. So Katie, I'll just say that basically what you just described is totally accurate. The medicine's called Lupron. And and I think the important thing with Lupron is there's really almost no downsides to using it. There's some data in breast cancer patients that maybe there's an increased return of menstrual cycles, which may be, insinuating it's somewhat protective. We don't have data on other diseases, but we use it as standard of care here at Primary Children's in Utah, and I just encourage others to ask for it because there probably isn't any downside to it. But it shouldn't be confused with sometimes we've had patients where they feel like they've had the best fertility. It's not a source of fertility preservation, right? So just make sure that is clear when you're having those discussions. And I just wanted to emphasize, like, Katie's story is so illustrative in like so many ways. But I think, Katie, your additional story and it turns out to be the great embryo and the, after therapy, again, and Dr. Irene Sue mentioned this in guidelines and talking about using an EMR prompt, that it's really important to have these conversations right up front. But for those who don't preserve up front, or maybe they do, like, Katie, you did, but there are opportunities and really things to think about after you're done with therapy. And there's a lot of sometimes nuance there on the insurance front and also medical front as far as hormone stimulation. And I would just encourage. I have seen patients anecdotally that their team sometimes discouraged trying to get fertility preservation afterwards because of the hormone stimulation. So just make sure on the back end, you get, sometimes there's second opinions that need to be had as far as the safety of doing hormone stimulation to get another oocyte or egg or an embryo. So nice job. Congratulations, Katie. That's just an incredible story. Thank you for sharing it.
Yeah.
I would say Joyce. Okay, so Katie answered the question about coverage of the and Joyce, is Lupron usually covered in all the states that you've okay. I don't know.
I don't find Lupron always covered, and Lupron can be expensive. So I think that that just has to be investigated. And ASCO, the ASCO guidelines has wrestled with this for several years, and as Doug said, I think there are some studies that show a possibly beneficial effect for breast cancer patients, but strangely, like not so much in other populations. So I do think you have to talk to your oncologist and your reproductive specialist about whether it's appropriate, and why, and what the side effects are, and all of that. So, and again, not a doctor here, but the only thing I wanted to also throw in is that I think you guys all see that Katie was an exceptional advocate for herself, and it was really a lot of work. So, I mean, that's why as much as you can help patients through this, it can be so daunting. And she was in a place, California, that had just passed a law. So, I mean, ostensibly, there was coverage, and it was still unclear. I think what's happened early days in many places when a law gets passed, I don't know if this is by design or it's just part of the process, but insurance systems have to adapt, they have to change. I think particularly where insurance plans don't cover infertility, you see a lot of rejections that are wrongful, that once fertility preservation takes hold, that they don't really understand that distinction. And because the service codes that are used are the same. And so they have to rebuild on the insurance, and they use a lot of algorithms. And so they're putting these claims through in a very kind of rote manner. And so sometimes you have to be ready and kind of be confident about what coverage exists to know to fight it. So it's just it can be cumbersome. I think it's getting better, but.
And sometimes you have to, in certain states, certain cities, certain areas, you have to advocate as a patient for yourself because it's not necessarily brought up depending on the age. Some people, I've heard stories of some people, a provider has said, just assumed you have a child already, maybe you don't want another one. So I think it's shared decision making, having that conversation at the very beginning, if you're of age for fertility preservation, depending on your cancer type. I think we have time for one more question. Does anyone else have a question for Joyce or Katie or for our team?
I'd like to ask a question if that's okay.
Of course.
For Joyce, we're working on incorporating the new ASCO guidelines into our fertility policy updating, and we struggled with the Lupron question because it so specifically says for breast cancer patients, and I get why it says that because that's where really the only research has been done. Am I correct about that?
I think there are other studies that have been done in other populations that didn't show a benefit. So I think that's where the controversy comes. I mean, and I don't want to put out the wrong information, but if I recall correctly, there were some studies like in Hodgkin's patients and things like that. But I can look into that further, Carol, and send you other information. And there are resources that are cited in the ASCO guidelines, but it has been for many years, a source of much debate.
Yeah, and we just really just want to say, especially if you can't preserve for whatever those many reasons might be, that yes, please use this if you want. Um, and we're struggling with using that verbiage. Would you say the ASCO verbiage does give you permission to use it for those who can undergo, egg freezing and such?
Yeah, I think what the main concern I've heard is that is being, as Doug sort of alluded to, like overly reliant, or so you
Mhm.
don't. I think when and if there's time, you're still
You don't want to use it in place of for
Yeah,
sure. Yeah,
exactly.
I
Because
get it.
I've
Mhm.
definitely encountered patients over the years, many years in this space, who were told like, oh, we're just going to do this, and this is what we're,
Mhm.
and then people come out and they're not fine. And I think I know we've had other talks on this. I mean, and again, I'm not a clinician, but I think part of the problem with this whole area of fertility preservation is that people's uh, underlying baseline fertility is so different, right? So you
Mhm.
really don't know. And as Katie mentioned, you know, her mom, she knew when she went into menopause. Of course, it's not necessarily a one-to-one, but some people just have a lesser reserve. And so, it's even more important and how individuals respond to chemotherapeutics or whatever, you know what I mean, it is going to vary. So it's
I think
very hard.
age would be so big of a factor in there. So
Yes.
yeah,
And I
yeah.
think, as
So
Katie said, we are trying actively, I will say, as we work with regulators, even in places where laws have been passed, where coverage has been passed, to try to make the case for also including post-treatment preservation. So, especially for younger patients, really younger teenage girls, things like that, who do have more of a reserve going in and do come out with a certain amount of time, maybe, which they still would be have reserve, but not necessarily, you don't want them to rely on that and wait either, right?
right,
So,
right.
so there's been a lot of advocating going on lately for incorporating post-treatment preservation. And I think arguing for that in
Interesting.
specific cases would be important.
That's interesting. I'd be particularly interested in the data on Hodgkin's. My niece was just diagnosed with that. So yeah, thank you. That was exceedingly helpful.
And good luck.
Allison, do we have time for one more comment on that?
Yeah, yeah. Make it one more comment for sure, and then we'll go to our survey, please.
Yeah, I just want to mention that I think one way, Carol, to consider it is what we've written in as far as institutionally, which we haven't seen any problems with insurance, is we just say we're using it for menstrual suppression, which can decrease on like vaginal bleeding versus times of like low platelets and other things like that. So that's another indication, which I don't think you should probably get much pushback from insurance on the coverage on Lupron. And again, I'll just also mention, we're talking so much about insurance, which is all this incredible work, and that would just be magical if everyone was covered and it was easy. That we had insurance for Katie, and it was still very hard. But I'd also just say that the pre and the post therapy, there are obviously lots of things, and we have tons of resources that we've highlighted and that we'll continue to highlight on different organizations, non-for-profits that help patients. But some of them are designed for either pre or post, and the advantage of post is you usually have some more time. But some services, some national non-for-profits are focused on, pre-start, starting before you start chemotherapy. So those are also just some nuances and logistics to kind of think about. But there are other things if there is no insurance coverage to consider.
We are at the top of the hour. If you guys will take an extra minute and fill out our post-session 6 survey. Next month is our last session. We want to make sure we're covering the topics that you're interested. We want to hear about what you learned today. And we'll discuss next month also how to claim your nursing and social work credit as well. But I'm going to pause for just a second so you can scan this QR code, There's a link in the chat. You'll get a link from me with follow-up to the recording, to the resources that were mentioned today. All of them will be in that resource sheet. If you have additional resources, please email me directly at allison.rosen@cancer.org and I'll add them to the resource list because I saw one pop up in the chat too, and I want to make sure everyone gets access to that. So we have our last session in March next month. Um, Dr. Fair and Olivia Frias are going to talk about kind of sum up everything we've talked about today, but how to build a fertility preservation program. But again, I know that they've taken the feedback from your surveys each month and built their PowerPoints and what they're going to talk about based on what the need is from you all. So please, as you are filling out that survey, give us feedback and I'll provide it back to them. But I just want to say thank you to Joyce so much for the amazing information. It's complicated, but it's much needed, and your work has impacted so many lives, including mine. Thank you, Katie, for sharing your story. Um, Again, every time I hear a lived experience expert share on one of our ECHO programs, it's truly touching, it's heartwarming, and I appreciate your vulnerability in sharing. Also, amazingly impactful today. Thank you to our subject matter experts, Dr. Fair and Olivia, for being on today and sharing. And thank you all to you participants. Again, if you had a question and you still want it addressed and you didn't have time, send me an email and we will get you answers. But again, I know we're 2 minutes over. I appreciate you all sticking around. Thank you, everyone, for being a part of this echo, and we'll see you at our last session next month.